feel a good spring. Should be springy. Should be painful. And I can get more specific there. Through that muscle. It's harder with people, a lot of muscle bulk tissue there. Right there. And I can get up pretty high on him. I'm just going to spring right along there for the individual rib. Flat hand. All right across there for the group of ribs. Okay, so if we go up here, about that much space to work with, pretty decent size there. So we get up to about right about T2. Thing swings out. Group-wise, I can get in there pretty good. Individually, not as I am so big. So there.
I have a question. Why are we doing this?
Okay, so that's what I'm going to show you. So, really looking for, when we do this, as you spring, you should note any hypomobility, something not move. So you can do some breathing, see if something's hypomobile there. Come in and spring those ribs. So you're looking for pain. A lot of people have some sort of rib dysfunction where it's caught up or down in those breathing movements. Sometimes it gets caught up, sometimes it gets caught down. You can also assess for fractures. If somebody gets hit, dodgeball, injury, that kind of thing. So you're looking for first hypo or hypermobility, probably more hypo than anything. Pain. Is it painful? Sometimes you'll note that they have a real painful posterior transverse joint. Sometimes, along with the thoracic spine motion restriction, they'll have some restricted mid-rib mobility. So we're going to treat both of those. Looking for also some neurological stuff. So if you find an individual segment, you can also a lot of times palpate it directly into those shingles, into the exact dermatome that's affected.
So most part of these patients, like trauma patients, like
thoracic spine, yeah, you're going to see a lot of postural stuff that people aren't aware of. But most people that are going to come to you with true thoracic pain are going to be rib contusions, some sort of thoracic trauma. They get pushed backwards, or bent forwards, or something like that. So some sort of trauma. And I also assess these with a lot of your respiratory patients.
Post-op.
So do you normally watch them breathe and feel that before you go in?
You got to do the whole assessment. That's what you want to do. Really come in, find your rib assessment. Take a deep breath in. So I know he doesn't breathe as well on his right side as he does his left. He's got more excursion on his left. So let me go in there and check it out. Is it because of hypomobility? Is it because of pain? Is it because that's just his habits? You'll see this. You can use this a lot in your acute care. You're going to see people with respiratory COPD. You have to watch. Also, be careful with notice they've taken steroids, those type of things that may lead to osteopenia. But you can use this in your COPD patients, asthma patients. People who've had chest tubes, ventilator patients. Those vents don't always push the air down, inflate all the lung. So sometimes they'll inflate upper and middle, but not get down the lower lung. Pneumonia patients. We have a lot of chest pain, don't utilize those lower ribs. We see a lot of different diagnoses. So those you're looking for hypomobility for. And long as, okay, if it's hypomobile and painful, or if it's just hypomobile. Those are primarily the things you're gonna look at. Obviously, there's neurological stuff you can, shingles, and things like that you also can evaluate along with this. So if they're really painful at T10, okay, you can check sensation.